It certainly is my pleasure to be here today. I had pages and pages of notes and we have about an hour. So I will kind of fly through a pretty high level of information and then certainly will leave plenty of time at the end of the evening for questions that you have and things that I may be able to address. The benefit of that work and the position that I'm in now is it really is the full age spectrum of our youngest children in the state within our Birth to 3 program who qualify just by having a developmental delay, so they don't even need to necessarily be needing a long-term care service in the future. In fact, our hope is that they will not, all the way up to the Older Americans Act, which many of those services are provided to healthy older adults who are living in the community, and then of course our full spectrum of long-term care services for people with developmental or intellectual disabilities, physical disabilities, and the older population that actually has some frailties of aging. And I do think that the common thread throughout that process has been being person-centered. And I think when you really begin from that perspective, whether you're working with a family, with their baby, and the concerns that they have about what their future will mean based on some developmental issues, young adults who are looking at leaving high school and finding employment in the community, people who might have a disability later in their life that is often called an acquired disability, and then of course all of us are on the path to becoming older citizens, and hopefully, and some of the things that you'll see in my later slides that we're very focused on, is how do we help you age in place, age so that you are as healthy as possible and as independent as long as possible. And one of the maps, and I'll spend a little more time on it when you see it later, but if you look at it, it's Wisconsin on the left side, kind of green, and Wisconsin on the right side, very blue. And what that indicates is blue, the more blue the map is, the older the individuals are that are represented in that. So as Helen Marks-Dix from the AARP points out to me, one of our central focuses obviously should be keeping older adults healthy, and all of us working on that right now, if you will. I won't spend a lot of time on our structural organization, but it does actually underpin some of our history as a division. And we have everything from the Bureau of Center Operations, because Wisconsin does still have 2 developmental disability centers, Central Wisconsin Center and Southern Wisconsin Center, where we have people who are residing there on a long-term basis, and Northern Wisconsin Center, which is more intermittent crisis intervention, intensive treatment program. And certainly many states have moved on a path to eliminating those very restricted, very institutional settings. Wisconsin has not achieved closure of our state developmental disability centers, but we have very effectively made sure that we have not just created mini institutions as we have moved people from those state centers. So a lot of states maybe moved people from a 100 or 200 bed facility, but they still have 60 bed or 50 bed kinds of facilities in the community. And for our community services for people with developmental disabilities, we do not permit a setting larger than 8 beds, and our focus is really on 1 or 2 beds, or better yet, the person living in their own home with some supports coming in. Our Bureau of Aging and Disability Resources has everything from the Older Americans Act services, things like home-delivered meals, nutrition programs, falls prevention, early identification of Alzheimer's disease and other dementia. And then it also has some of our specialty offices, for people who are blind or visually impaired, deaf and hard of hearing. And then a focus that actually cuts across our division and across our department is our Office of Independence and Employment, recognizing that all people with disabilities have the capacity to work, within the community without the idea that people should be in a segregated setting in order to work. Our Bureau of Long-Term Support is where the children's programs are, including our Birth to 3 program. Wisconsin serves far more children than any state in the nation on a per capita basis. Our Katie Beckett program, which is on that resource list that you have, it confers Medicaid eligibility based on the complexity of a child's needs without regard to the family's income and assets. We have nearly 5,000 children on that program. We have comprehensive children's long-term support waivers. Federally, they use a term called target group, which we're not very keen on, but it does have meaning nationally. And that includes children who have intellectual or developmental disabilities, children with physical disabilities, and children with severe emotional disturbance or complex mental health needs. And we are serving, and I'm looking, Jessica's here. I would say, again, 4,000 children. Yeah, it grows continuously, so we have a lot of children receiving services. And then we have our legacy waivers. In a little bit, I will talk more about all of our waivers and give you a bit of context on that. And our self-directed supports across a variety of programs are in that bureau. Financial management, I think when you see some of the figures a little bit later in this presentation, we are talking billions of dollars with a B. And so the complexity of managing services and supports and assuring that we are cost effective really consumes a great deal of a full staff time. And then the big office is the Office of Family Care Expansion, where we are close to 40,000 people receiving their long-term supports in a managed care environment. And again, I'll talk about that a little bit more in a moment. One of the things that I feel very proud of with our department is that we actually are talking directly with the people who use our services. We are talking with their families, we're talking with them, we're talking with advocates who represent those groups, such as Disability Rights Wisconsin, the Board for People with Developmental Disabilities, and the Board on Aging and Long-Term Care, just to name a few. So we really have a long history in Wisconsin of sitting at the table together with people who need the services that we are developing and really getting direct feedback. And we have very collaborative relationships with those individuals. And it is one of the most striking pieces to me when I visit other states that are covetous of that type of relationship that we have. I don't mean to paint it as perfect. We definitely have points of conflict and concern and disagreement on how you might interpret something, but that is the work of having a partnership and working together. And so we're very proud of the specific councils and focus areas that we have. So I think an important concept to understand, and I do apologize if you already know a lot of this about Wisconsin's system, but I assumed that we would have a wide variety of experience in the room. So I kind of have everything from basic to a bit more advanced. Many states, Wisconsin included, in the 1980s were part of an effort to move people from institutional settings where Medicaid is an entitlement if your income and assets are low enough, to refocusing and rebalancing is the term that we use, of having services in the community. So in the 70s into the 80s, there was legislation that enabled the use of money that would have otherwise been used in institutional settings in the community. So the part of the Social Security Act that authorized that is 1915 paren C. We call them the Medicaid Home and Community-Based Services waivers, and even shorter, the waivers. So this is what we're talking about. What's interesting about the waivers is it's a waiver of where you use the money and what you can buy for it. So if you think of Medicaid historically and traditionally, it usually is buying health care kinds of services. You see the doctor, you go to the hospital, you get therapies. So the waiver is not only about the location of service, but it's a waiver of the types of services that we can provide. and we can have a community individual support focus and use those Medicaid dollars to do that within the waivers. So we include things such as respite, supportive home care, which is similar to chore services. We provide modifications to people's homes. We provide modified equipment so that they can be more independent in doing a task rather than having assistance. And then we do provide residential kinds of supports, not the room and board piece of it, but the other kinds of things. Maybe someone, if you need an individual to be there in the morning to help you out of bed, if you need someone overnight in order to assure safety. Wisconsin also uses the 1915 Paren B authority, which is where we can create managed care options. So we take things that are usually Medicaid fee-for-service, all those medical pieces, and we pull some of them in and say, you know, if we can coordinate these with long-term care supports, we're more cost-effective. Because personal care, which is things like helping you with bathing, helping with toileting, helping with dressing, eating, those are personal care tasks. But if I do the dishes after I helped you to eat, now I'm doing supportive home care. Well, if you have the same person doing that, it's pretty absurd to have two payers for that service. So part of what the managed care benefit allows us to do is to have some more flexible boundaries between those kinds of services. And it also allows us to provide a service that's traditionally considered medically oriented for different reasons other than, you know, it's an absolute medical necessity to have the service. So things like communication devices can fall into that category and become allowed. And then finally, we have the traditional state plan medical services, which includes acute and primary care. So in a little bit, I'll be talking about a variety of program names, and you have those on the list of additional resources with web links. That was one of the handouts. And a majority of these programs are Medicaid funded, either as fee-for-service or as the waivers. And so the way in which you combine those two federal authorities have to do with the payment sources for these programs. The reason Wisconsin is so heavily into Medicaid, as other states are, is rather than spending $1 of state money, every time you spend $1 that is allowable Medicaid, the rate varies a little bit, and the rate varies from state to state. But for Wisconsin, it's somewhere between 38 to 42% state money pulls down the alternate amount, so around 60% of the federal money. So it is a way of taking the money that we have and stretching it further. I often call it the Medicaid cookie jar, though, because if you put your hand in the jar, you have a set of rules and criteria that you need to follow, having touched that money. And I think often those are some of the policies and issues that we find challenging to balance satisfying all of those federal requirements with being responsive to an individual and what they need. So we have to do a lot of figuring out and creative thinking about whether things can be allowable. Wisconsin has kept some funding pure, where it is just state general purpose revenue that gives us some opportunity to not have to meet the federal requirements for certain services. So our community options funding, we often match a lot of it to our community options waiver. But if someone really cannot afford to live in a setting with what they have as their personal resources for room and board, we can take what we call COP Pure, which is the state money only, and fill in a gap for that service. Nationally, and this is definitely true in Wisconsin, Medicaid is the largest single source at 42% of the total spending for long-term care. Medicare is about 25%. People spend about 22% out of pocket, and private insurance and other sources are at only 10%. And that, I think, often surprises people because people have bought long-term care policies or whatever, but those are very tricky things, and often the point at which you need them the most, you can no longer afford the premium to keep on carrying the long-term care coverage. So publicly, we do end up paying for a substantial, when you add those top two categories, you know, we're at 67% kind of right off the top of publicly funding long-term care. This one I know is just way too small for you to see, but I wanted to be sure to talk with you about some of the numbers that I mentioned earlier. So in our family care PACE partnership and IRIS program, and just hold that in your thought, there is an explanation very high level on this sheet about those programs. That whole category we call our reformed long-term care programs. So we're serving about 43,000 people at a cost of $1.3 billion per year. And that is an all funds number, so it includes the state funding that's in it as well as that Medicaid drawdown. In addition to that, Medicaid pays for nursing home and other institutional care for just over 17,000 people, and that's at a cost of $973 million. And just to do the math very roughly for you, people living in an institutional setting are twice as costly as their counterpart living in the community. So one of the places when you look at how are we going to afford long-term care for that growing population in Wisconsin, part of it is looking at how do we support people better and longer in the community, certainly assuring health and safety, but also avoiding people being in a more restricted setting than they need to be. And we did a survey of people who have come to our aging and disability resource centers, which I'll tell you more about in a little bit. But we found that 83% of the people who were coming there needed some help to stay at home, but also wanted to stay at home. And even the percentage of people who were saying, well, maybe I need to go to an assisted living facility, didn't necessarily want to do that. They just weren't aware of solutions of how they might be able to stay at home. So that's a big focal point for us of how to really be able to sustain long-term supports in Wisconsin in the future. Our legacy waivers, so back in the 80s when Wisconsin first started serving people, we developed a variety of programs, in particular community integration program and community options program. The only difference is KIP, our abbreviation for Community Integration Program, focuses on the developmental disability, intellectual disability population. COP, Community Options Program, focuses on people who have physical disabilities and frail elders. And then more recently, we have, as of 2000, our children's long-term support waivers, which really took what previously had been largely state-funded services, and by being willing to enter into that Medicaid arena, we have been able to triple the number of children and families that are getting support within the community. So it makes a substantial difference. Here we're just under 300 million. If you quick do the math, the legacy waivers are just a little more costly than our managed care programs, but part of what offsets that difference is that children's services are less costly by and large than adult services, and that's because of the important role that school plays in young children's lives and prior to graduation. So where we spend a lot of money supporting people, adults in the community, is what do you do all day? And in the absence of school, we're spending a lot of money on support. One thing that we're really hoping to change, again with some of our sustainability efforts that we have undertaken, is the more we can work with people to have employment in the community, the less costly their care is, the better their quality of life is, and the more independence they have. We found that people who make as little as $400 to $500 a month in their employment by making a decent wage at a job even if it's part-time, that's enough to make a difference between whether they might live in a group home of 3 to 4 people or live in an apartment with a roommate. So it doesn't sound like a lot of money, but we know that that small amount of income for that individual, in addition to their disability income, can really make a difference on what happens for them. And then finally, Wisconsin has a very generous Medicaid fee-for-service program. We include all but one optional service compared to many states. And we have another 5,000 people who have long-term care needs, whose needs are primarily met through personal care and home health services within that Medicaid fee-for-service side of things. I'm going to skip this in the interest of time, but I will talk a little bit. Wisconsin has had enrollment caps in place on our reformed long-term care programs, Family Care, IRIS, PACE, and Partnership. Those started on July 1st of 2011, and the governor signed the enabling legislation to rescind those caps, and that became effective on April 3rd of this year, so just 2 weeks ago about. But one of the things that we can show is even with that, Wisconsin continued to enroll actually almost 5,000 more people in Medicaid benefits during that time. 500 approximately additional people into the programs that had the caps on them. And there is a complicated explanation behind that if you'd like to talk more about that during questions. And most importantly, Wisconsin is continuing. When I talked about in the 80s, we really shifted from people being in institutional settings and moving to the community. This data is as of 2009, but the blue line going down is the reduction in the use of institutional, including nursing home settings, and the red dots going up are the growth of long-term care programs. If you wanted to use your imagination to take those out a little bit further, the blue line is even further down and the red line is even higher up, which is very remarkable data for a state. So again, even though we have a ways to go, Wisconsin has taken and has diligently implemented the community promise. So let me talk a little bit about our reformed system of long-term care in the state. And this is another handout that you have in front of you. It's got the colorful map. And the way to look at this map is the areas that are pure white, which are largely the northern part of the state, as well as Adams County in the middle of the state, do not have any of our reformed long-term care programs at this time. The gray dotted area over on the eastern seaboard, so including Marinette County, Dorr, Brown, that kind of whole cluster right up there around Green Bay, is also not yet a reformed part of the state, but they are the part of the state that's ready to change in the not too distant future. And then we have Rock and Dane County right here in this area and kind of the lower center of the map. And those two counties also do not have our full array of reformed programs, but Dane County does have what's called a partnership program. So it's a bit of the way to look at the map. The remaining colors just show currently where there's a managed long-term care organization. So the blue part of the map is Northern Bridges long-term care. The red part of the map, Community Health Partnership. The green over here in the center part of the state is Community Care of Central Wisconsin. And I won't go through all the names, but all the names in this map are available on our department's website. So if you really want to look into that more fully, and I also have a link to that on this links page. So when we talk about the reformed areas of the state, those are the parts of the state where over 10 years ago, we started to look at could Wisconsin sustain the type of community-based waiver programs that we were operating. And the way I would describe our legacy waivers is that they were wonderful if you were able to get through the door. And if you were on the waiting list, they really weren't wonderful at all. And our waiting lists, like many states, were quite substantial. So what it meant is you might get Medicaid eligibility, you might be able to piece together some personal care and home care services that might help you stay in the community, but the lack of services was often a driver to people going to a nursing home or a more restricted setting. Or families doing without, piecing it together, being very stressed by trying to make things work. So part of what needed to happen, if you look at, well, if you have sort of the same pot of funding and you have people waiting, how do you begin to look at doing things differently? So what Wisconsin did is we took that 1915C home and community-based services waiver, wrote the managed care piece of it, which is that 1915B. So to be kind of crass, it allowed us to get our hands on some of the Medicaid money and pull it together and spend it on community supports. So some of the savings of doing that were managing things more closely, but also it was managing services that previously had not been managed. They were out in the fee-for-service basis. So if I met the criteria for getting personal care, I could just get it from an agency that delivered personal care. Or therapies, if I could get the prior authorization, I was just out there using them. Therapy, for example, may not have been what I really needed, but it was something that was available. So those savings are what created the capacity to serve more people. And then also there is a continued infusion of money, because once we moved to that combined authority, it moved the services from being services that you are permitted to wait for, if you will, to services that at some point our federal centers for Medicare and Medicaid, which CMS, which is our authorizing federal agency, at some point you have to move to services being an entitlement once you start to do managed care. And so the promise of family care then has been that Wisconsin is on a path to eliminating waiting lists, and in fact have done so in many parts of the state. Our waiting lists grew a little bit in those parts of the state while the enrollment caps were in place, but I got data right before I came here this evening and we're almost back to no waiting lists in those parts of the state just from the beginning of April. So again, something that you don't find in any state in the nation where there's any glimmer in the future of the idea of being at a status of no waiting lists for long-term supports. So the way that Wisconsin has then entry into that new system is the Aging and Disability Resource Center. And I know I've had this slide up for a little while, so you probably had a chance to read all the things they do. But one of their biggest jobs is to outreach to people. And the biggest challenge is to outreach to people before they are desperately in need of services. Because if we can do that, we know we can delay people's entry into long-term care. We know that we can work with them to try to prevent burnout of caregivers, burnout of living settings where you can't stay at the apartment building any longer because there have been just enough fires that you're going to be evicted because there's a safety risk to other people in the apartment building, those kinds of things. So they have a huge focus on outreach and prevention. And in fact, we are just on the process now of really increasing some of those efforts. We're using evidence-based practices around falls prevention, early identification of Alzheimer's disease and other dementia, and caregiver programs that really support and encourage people to take a bit of respite, a bit of a break from their caregiving responsibilities because they're healthier and they're able to actually have the person who has the care needs stay at home much longer. They also provide elderly and disability benefit counseling. which is incredibly important to keeping people independent. Sometimes those resources are just enough to keep the person at home and not yet need the deep end long-term care services. They link people to Meals on Wheels, home-delivered meals, some nursing services, medication management kinds of efforts, and fall prevention assessments in people's homes. And then obviously when people move along the continuum, if they do, of needing long-term care supports, they are determining functional eligibility and facilitating financial eligibility. So let me talk about those 2 points for just a moment. If you think of this overlay of the federal waivers, and we used to have people in institutions and entitled to that money, there's a federal test of meeting an institutional level of care to be able to get those services in the community. So we have to do an assessment and say, do you have needs? For example, you need assistance with bathing, you need assistance with eating, you need supervision because your judgment leads you to make choices that make you unsafe. So we look at the whole array of needs that the person might have, and we try to compare that to someone who would be their counterpart in an institutional setting. So that's what functional eligibility is about. And then the other thing is quite honestly, you have to be poor or pretty close to poor to be able to get public benefits. So the second piece of it is a financial eligibility determination. That actually happens at income maintenance organizations throughout the state. Just recently, those have moved to a multi-county, multi-area consortia. It used to be individual counties operating that. But the ADRCs are very beneficial in helping people pull that information together. Our ADRC staff describe people coming in with the shoebox of all the information. Tax preparers talk about people with the shoebox too, with all the bits of paper and helping them to sort through that. So the person has to meet an institutional equivalent level of care, and they have to be at the income and asset level that people would be if they were allowed to be admitted to an institution on public funding. And then finally, ADRCs do link people to adult protective services. I'm sorry I didn't catch that abbreviation. And elder abuse prevention and intervention. So clearly if someone comes there with any signs of abuse or alleging abuse or neglect, appropriate referrals are made. ADRCs are for adults. So at about 17 years, 6 months and beyond, a person can be referred to an ADRC. They're very good about not turning anyone away. If someone comes into them with a question about a 16-year-old, for example, or a 10-year-old, they try to make the appropriate linkages, but their focus is on the adult long-term care population. So here's the laundry list of program names. And I was thinking about this. I wish our system weren't so complicated, but it is because of how it's evolved historically. So family care, as I mentioned, is that we pull a little bit of the medical services in with the community service. It's a managed care arrangement because that long-term care managed care organization receives a capitated per member per month payment, and then has to manage all the services for the people that choose them as their long-term care provider. So some people's costs will be lower than what they're paid per month. Some people's costs will be higher. And then the rates are structured actually based on the data of people who are enrolled in the program. Family care partnership takes not only the community services, but rather than some of the medical services, it pulls them all in. So if a person enrolls in family care partnership, that team is working with them not only to manage their community supports, but they're connecting with the doctor. They're working on trying to avoid hospitalization and emergency room use they're looking at providing better care about chronic disease and conditions. So it's a much more comprehensive approach. And here, the managed care organization is not only getting that capitated payment from the state, they also get a capitated payment from Medicare. So there's two sources of funding that are blended together to meet the needs typically of a group of people whose needs are more complex. A little sidebar is that there is an additional program called PACE. And PACE is essentially prepaid no, I'm not going to get the acronym right.
It's Program for All-Inclusive Care of Elders.
Thank you. Oh, I appreciate it. Program for All-Inclusive Care for Elders. And the basis of PACE is that there is a day program at the center of it. And then not only are your community supports coordinated, but so are your medical supports. Wisconsin does have a new initiative called Virtual PACE that we're actually just now getting ready to submit a federal proposal on how we would do that. And the reason it's virtual is we wouldn't require that day services component of it. So anyhow, I've got a link on this list for you to find out more about that program. So those programs operated in the reform part of the state for about 8 years. And then federally, Wisconsin was directed that because so many parts of our state have only one managed care organization as a choice. Right now in the blue counties, your choice is Northern Bridges of Wisconsin. In the red counties, your choice for managed care is Community Health Partnership. So because of that, we were told that's not really a true choice for people. And Medicaid always requires that people have a choice. So Wisconsin submitted an additional waiver that operates in all of the reformed areas of the state. And it's called IRIS, which is Self-Directed Supports Waiver. It does actually stand for something, but we mostly call it IRIS. And this one I do have the ability to pull off my brain, which is Include, Respect, I Self-Direct. So that's the source of the letters, but we pretty much, after we named it, we just call this program IRIS. And what happens in IRIS is same criteria. You have to meet that institutional level of care. You have to be financially eligible. But we calculate how much money would probably be spent to meet your care needs if you enrolled in family care. And you can plan for your long-term care services within a comparable budget. And so the person has some additional flexibility. They can hire their workers. They can do some creative things. We have a service called Customized Goods and Services, which might be just like that little fill-in-the-gap piece that you need, and then you might be able to be more independent in working or creating a small business that you operate. That's been one of the more common uses of the flexibility that people have within IRIS. People in IRIS still get all of their Medicaid medical services through the fee-for-service system. And one of the things that we're looking and trying to make this program also as cost-effective as possible is what's spent for your services in Medicaid is kind of a black box for people. And we think if people were given more information about what the cost of their Medicaid services were, they could be more informed consumers about what they are or aren't using. We actually do this in the Katie Beckett program. Families are able to get the statement of what was spent on their child's behalf in Medicaid, and families are diligent in making sure that visits that are charged actually happened, and making different choices if they realize that by going to get therapy here, it's considered outpatient hospital therapy as opposed to community-based clinic therapy, and it costs a lot more money, even if you see the same physical therapist in those two settings. So we want people to be informed and to have cost information, and that's one of the next efforts that we will be doing. And then the legacy waivers, HIP COP continue to operate in the parts of the state then that do not have family care, which is then where the term expansion comes into play. So when we're ready to go to a new area, we have expansion activities that take place. And managed care organizations, the type of organization that provides community care as opposed to a managed care organization that provides health care, really was not an industry that existed in Wisconsin as we started to create family care. So what many of the areas have done in the state is actually developed either a family care district or used some of the other organizing authorities and have built organizations from the ground up. In order to expand into a new part of the state, there's a series of things that have to happen. First, because the long-term care services in the legacy counties are managed by the county board or human services board needs to take a resolution that they want to enter into planning. So that's one of the first steps. They also have to begin planning and implementing an Aging and Disability Resource Center. In addition to that, as that planning moves along, and they're actually interested and ready to move forward with long-term care reform in their county, there has to be an additional resolution. And the simple framework for why there has to be that resolution is there's not only state money matching the federal funding in Wisconsin, there's county money. Through base community aids and local tax levy, there's local money in long-term supports. And so there's a buyout process when a new county comes on board into the reformed programs. So they're not allowed to just walk off with the long-term care money, but it's a big decision to turn over control, if you will, for that money and make that transition to the reform system. So that's yet another step that needs to happen. And then our department has to show that it is cost effective to move into a new area, and we have to present that budget information to the Joint Committee on Finance of the legislature. So there's then a state legislative decision about going into a new area. So all of those pieces need to be in order. One of the things that changed about that expansion piece recently is as the caps were lifted, there also is new language around expansion where rather than a passive review by that Joint Committee on Finance, it's now an active review. So the difference is that if it used to go over for 10 days, and if nobody objected to us moving forward, the department would issue a request for proposal for managed care in a new area. Now it has to be actively scheduled. It has to be on the docket for consideration by the Joint Committee on Finance at the legislature, and they actually have to take an active vote about whether the program can expand into a new area or not. And I'm going to give you a little background briefly on why that happened. So we have these big programs we've been changing substantially here in Wisconsin, and the Legislative Audit Bureau, which is an independent, nonpartisan audit bureau for our state legislature, required an audit of the family care program. And the audit addressed several concerns with family care that they indicated were very important that those be addressed. If you are really interested in that, I have given you the link to their report as well as the department's response to that report in your resources page here. But basically, they were concerned and felt that the department had to do a better job of showing that managed care created good access to cost-effective, quality, long-term supports, that people truly have a choice and the ability to self-direct their care, and that the managed care organizations that administer the program have sound programs and financial management practices. An important overlay to when this study was done, and it's part of the department's response, is managed care organizations take 3 to 5 years to mature and really be able to work within that capitated rate and manage within the funding that they have, plus have the reserves that are required for them to be considered a stable organization. So by its very nature, a brand new managed care organization has to work on stability. So we certainly have matured, and the program has matured from the time the audit was done, but there were still important questions being asked that needed to be addressed. Concurrently with that, and I have already mentioned, our long-term care expenditures this year alone will exceed $2.8 billion in all funds. We are 40% of the state's overall Medicaid budget. And in July 1st of last year, as many states did, we experienced a massive reduction in our federal funding. So this is the other challenge of having your hands on the federal funding in complement to the state resources that are available. And if you look here, we had a reduction of $660 million for the first year of the biennium, which is where we are right now, and $666 million for the second year of the biennium. The governor and the legislature did infuse about $1.2 billion into the program to work on offsetting this, but it left us with a difference. And that difference is in part what compelled the short-term cap on long-term care enrollment. And the charge to us at the department and in working with our partners was to identify the money that is needed for that gap. The third overlay to the challenge of why our programs need to become more sustainable in the long run is that map that I referenced earlier. We already have a lot of people getting long-term supports. We need to anticipate more in the future, and you really have to have a strong program for us to be able to keep our promise of long-term care in Wisconsin on an ongoing basis. So with that, the department has developed what we are calling our efficiency and sustainability strategies. This just lists very broadly some of the areas, and I've talked about some of these as I've been talking with you this evening. So living well in the community, if we can do falls prevention, if we can identify Alzheimer's earlier, if we can have youth leading to employment in the community, all of these are things that we anticipate that we will be able to locate, and my slide's a little goofy, but the $80 million in savings that we need to remain within our budget in the current biennium that will end next June 30th, 2013. So I'm not going to go through these because I know we started late and the time is a little short, but I have given you the link to our 2011-2013 long-term care sustainability plan. I'll just highlight for you that we have 7 areas of focus. Residential services, the idea of what can we do to keep you at home longer. If you've ended up in a more restricted setting like a nursing home or an assisted living facility, but we could support you back home or back in an apartment in the community, can we work with you to do that? So that's what that initiative is about. Youth in transition, this one has, I would say, 2 layers to it. One is working and one is where you live. And as I mentioned earlier, anywhere between $400 to $500 a month in earnings makes a difference where you can live and how independent you can be. And yet we find a lot of pressure on families who have really fought for inclusive school services, have fought for their child's right to be fully included in education and not in segregated classrooms, get to the point of graduation and are at a loss for how to fill that young adult's entire day, because these are also families who are by and large still working age. So they have to be off earning income, but their child is now an adult and graduating anywhere between 18 to 21 years of age. And what are you going to do with your whole day? So that's our focus in this area. We want to strengthen self-directed supports. I mentioned that the IRIS program is relatively new on the scene. This is our self-directed support program. We have nearly 6,000 people enrolled, and the original impression of this program was that it was going to be kind of boutique, and maybe we would have about 750, maybe 1,000 people enrolled. And quite candidly, our infrastructure for IRIS presumes that this was going to be a program of 1,000 people or less. So it is sitting on a very fragile infrastructure. We have 12 different IT and data systems that try to piece together a full picture of the person's assessment, the services that they're receiving, what's happened with the actual implementation of their service plan. And we certainly cannot operate a program on an ongoing basis in that way. The other piece is that our secretary of our Department of Health Services, Dennis Smith, is very committed to self-directed supports and wants to triple the number of people who are self-directing. Now that's not just in IRIS, because people can self-direct their services as well in family care, but even if this number doubles, we are concerned that we could collapse the program if we don't put the proper infrastructure around it. So we're already flying the plane, and now we're trying to build the rest of the structure that we need to keep it afloat. Living well in the community, I probably talked about this one the most because it's so easy to do examples about it, but we really want to support people sooner. One of our aging and disability resource directors said to me, he said, you know how much most people want to talk about funeral planning? Well, talking about the need for long-term supports is a close second. So we often have people where families don't want to talk about it. They don't want to consider that their parent may not be able to stay in the family home or in their house. And then typically it's at the point at which things have disintegrated, and then they're looking for a quick placement. My joke about that, and the exception to that, is that I come from a Scandinavian family despite my married Polish last name, and we talk about death and dying at every single holiday gathering. It's not a taboo topic in our family, but I do realize it is for most. And then when you think of long-term care planning being comparable. Family care benefits, even in family care, you know, earlier I showed you that slide that showed that we spend almost twice as much on a person living in an institutional setting as in the community. In family care, although a majority of the people live in the community, in their own homes or an apartment, a majority of our funding goes to residential services. So even within community supports, there's that imbalance of how funding is spent. And that is just one example of an area of our family care benefits that we want to shore up. I think the other thing is because Wisconsin has this robust system of long-term supports, there is a tendency for us to pay for things that people might have done or have been willing to do informally. So we describe that as natural supports. And what we know from all of the long-term care research is if you have natural, your neighbor, your family member, a daughter who checks on you after work, a parent who connects with you to see if you need anything, you are much safer in the community, you are more included in the community. We have had an unfortunate tendency, however, to decide that people would only want to do those things for you if they're paid. And this one, I think you can just tell by the description of it, is a tightrope, because if you go too far one way, we can burn out caregivers and exhaust them physically and financially and emotionally. But if we go completely the other direction, it gives the message that we don't really value people who have long-term care needs and presume that no one would be in your life unless they are paid to be there. And there's a balance that we're going to be working hard to try to identify in that area. And then, like anything, we have a level of bureaucracy. Our department has contractual requirements of managed care organizations Some of those are compelled because we're touching the federal funding, but some of them have sort of grown up over time and were maybe there because we were working with new MCOs that hadn't really matured, and now we're demanding things that probably aren't as effective as they should be, and they've reached a level of being burdensome. So we're also looking at ourselves and how we interact in having our long-term care system in place. And then the last area is not just employment for youth, but our percentages of adults with disabilities who are employed is low, and we know we can do better than that. And again, for the same reason that we want to support youth with disabilities and long-term care needs to be employed, the same is true for adults who are interested in working. So I think with that, here's just a highlight of the next topic for the next time around. But our children's long-term supports have not been included in this adult reform effort. But as I mentioned, we are providing a lot of children's services, and we know that children will eventually be receiving supports in our adult long-term care system. So this is a beautiful vision statement that our Children's Long-Term Support Council actually developed. We want to support children with disabilities and their family to pursue unique hopes and dreams, that assistance should be family designed and controlled, individual and seamless, and the last as long as needed. I would say families are saying we need to be able to count on it. It can't be that maybe this month we can get something, next month we can't. And definitely want to be connected to their community. When I send the presentation out, there is a link here to a very easy read. It's about 20 pages, but it really outlines the vision for children's long-term support systems change on these 5 key measures of how easy is it to access services, do I have choice, are services coordinated, which is a huge challenge for children because we have not only long-term care, we have the healthcare system, we have schools, there's a lot of silos. We want to have quality services, and we have already been reforming the funding. One piece that we've been doing is looking at, is there a way to consolidate intake into long-term care services for children? That's called Compass Wisconsin Threshold, and I have the link for more information. We're piloting that right now in Kenosha, Racine, Walworth, and Waukesha counties. We will be expanding a bit more, and incredibly positive feedback from families about how much better that works. And the other work that we've been doing, not only with our staff, but working with counties, is talking about what our North Star is, which is children and families. We felt that for a period of time we were getting wrapped up with our North Star being federal regulations and compliance. And so we're really shifting where we're focused. And then one of my favorite pictures here is the dimensions of inclusion. This was developed by John O'Brien and Connie Lyle O'Brien, and we've had them doing a lot of work with us. A lot of times, you know, people look at inclusion, and I know you've all been at the mall where you see 10 people who have a disability all together with 1 or 2 support staff. And yes, they are where other people are, but they're not really in the mall in a manner that includes them in an ordinary way. And so Connie and John have this wonderful way of thinking about how we should work with families. And our goals about true inclusion are people with disabilities being respected, sharing ordinary places, being at the mall, but being there like all of us would be there. Contributing, the idea that people do want to work, they want to volunteer, they want to have a meaningful role in the community. Choosing, which tends to be the part of the picture that everybody likes to focus on. And then belonging. And really looking at how do we work with families about thinking about this and how they would be living their lives even if their child did not have a disability, and looking at how we really connect them. So more about that if you come to the spring effort, or this is the spring one, so the fall effort. So with that, I think I have probably run through the information quickly enough and should stop and see if you have questions. The question is, are the people who are enrolled in family care reflective of the race, ethnicity, cultural diversity of the community, the county that they're in? And I would say by and large, we see that that is the case. But we also require ongoing outreach. We require translation services. So for example, we do not consider it acceptable for a family member or a child to be pulled into doing translation with someone about their health care or their long-term care needs. So we require that. We are working closely with the tribes in the state to make sure that long-term care supports are responsive to the tribal nation and their culture. And one of the ways that we're doing that, and this applies to other, also to racial and ethnic groups, is looking at how do we increase the provider network of people who are from that community. So to use a specific example, Milwaukee actually has a large Eastern European population, and they have, the managed care organizations there have been fostering relationships with providers who are from that community. So I would never say that we're there, but we do have that awareness and that goal. Our cost analysis, and it actually is part of some of the papers that the department has up around our response to Legislative Audit Bureau and to our sustainability efforts. Right now the cost of IRIS on a per person basis is modestly higher than family care, and that's when we pull all costs in. So we're not just looking at the community supports, but we pull the card supports in as well. At the same time, when we adjust for acuity, the difference is very small. So when I think about this, it's not surprising to me that people who have more complex needs in some instances are choosing self-directed supports because they want to have control over who is providing that service and having that ability to directly choose and hire, for example, who's providing some of your personal care if you are very physically vulnerable is probably more important to you. But it does fit with the comment that I made earlier, is there is that whole black box of Medicaid costs where if I go to the doctor, if I go to the emergency room, if I take therapies, we want people to have tools to know how much that's costing because we think that that could help them to bring their Medicaid costs into management by doing it on their own. And then the final area is when we first implemented IRIS in Wisconsin in 2008, there was a great deal of worry. I talked about all of our councils that we have on one of my earlier slides. There was a great deal of concern from the advocacy community and from our IRIS advisory committee that you have to have budgets be more generous when a person is managing on an individual basis because they can't leverage volume purchasing like a managed care organization could. So the worry was they may not be able to get that discount, so would they not have enough money for their supports? So the department applied an adjustment factor to individual budgets, and we applied far too generous of an adjustment. It turns out that people self-directing are very creative and they may not have volume purchasing, but they can be creative and spend less. So we see that people are not spending their full budgets. So anyhow, it's part of, I kind of think of IRIS as being much like a managed care organization in its first 3 to 5 years of development. Over time, we would expect the cost to at least be comparable. So it's a long answer, but it had complicated parts. So the downside of family care. You know, I think when any of our programs are well managed, I don't think that there's a downside. If we are being responsive to the person and what they need, and working with them on the different ways that we can get the supports, I think that we have two big challenges. One is there are still many parts of our system that are provider driven rather than driven by what the person needs. And so that is a very substantial issue. And the other is helping people to understand that public supports fit into their life, they don't become their life. And that's a very challenging piece. We have something called the Resource Allocation Decision-Making Tool, or the RAD, that's supposed to help you say, well, there's more than one right answer to the problem, and which is the most cost-effective approach that reaches your need. But we have a lot of work to do with our care teams, really understanding how to do that, so it just doesn't feel like a mysterious tool that delivers an answer. And we also need to work with people about, we're just part of the whole picture of the supports around them. And that is not Wisconsin's history, nor any state's when you look at how much institutional care we've had in the past, which is a very costly solution. So I kind of see the whole system as evolving. We're not there, and that's the work we have to do. So I use the word partnership, thank you, in describing Dane County, and the question is, what exactly does that mean? So when you look at that map of Wisconsin, Dane County is still operating the legacy waivers for people with long-term care needs. However, there is one managed care partnership organization, so that's where it's the community supports plus the medical services all pulled together. And so people in Dane County can choose to enroll in partnership. And so they have one managed care product that is serving some people in Dane County, but the majority of the system in Dane County is still what we would call legacy waivers. So it doesn't have family care and IRIS yet. The services in Dane County are still operated through the Human Services Department. And so maybe to take that one step further, because it is one of the questions that I got in advance. So if Dane County wanted to move towards becoming a family care and IRIS county, they would have to follow all those steps of a county board resolution for planning, a county board resolution about the buyout of the county funds and sending that money over to the reformed system, us being able to show it's cost effective, and the legislature approving it. So all of those steps would need to happen for family care to be in Dane County. Yes, so the question is, has Dane County received money to begin developing an ADRC, the Aging and Disability Resource Center? And they have. The current biennial budget, so for 2011 to 13, includes funding for all counties to have an ADRC. So Dane County is on a path to do that. We do have ADRCs in counties that don't have family care and IRIS. Brown County is one of the counties that comes to mind. And in that case, the ADRC is still doing that, almost 80% of their work, that is connecting people to existing resources, that whole long list on the ADRC slide. And then to the extent that people have long-term care needs, they're helping them to enroll into our legacy waivers rather than family care and IRIS. So an ADRC has a different role in a non-family care county. Similar but different. So the question is, what percentage of the state is family care on sort of a population basis and what percent isn't? And actually I believe that the percentage that we've hit is either 80 or 85% of the state is part of the reformed long-term care system, and the other 15 to 20% is not. So we are in a majority of the counties with long-term care reform at this point. Wisconsin has 72 counties. And I'm trying to quick do the math in my head. I believe we have family care in 58. So the question is, what's the dollar figure to complete family care expansion in the state? I think that there's two parts to it. One is that the counties that remain non-family care need to be willing to enter into that same agreement where the money comes forward into the new system. So that's definitely can be one challenge about moving forward. And then that money still does not support all of the people who would then be coming off the waiting list, and that's the second part of the calculation. And the new structure that we have for being able to expand family care includes not only the department and Centers for Medicare and Medicaid looking at those numbers, but now our state legislature to see if everyone agrees on a correct dollar figure of what new funding needs to be infused into the system. So I don't have like a number I can pull, but those are the factors that build into it. So the question is, the Dane County, that money that would come in as part of the buyout of coming into long-term care reform, is it earmarked to always be committed to Dane County, or does it go into the broader pot? So I would answer the question, it comes into the larger pot, but that amount of money will always be expended in a county because it's not the full funding picture. So also new money is coming to the table to serve people who have never received services. So people who live in a county area don't lose out on the money that's committed to providing them services. We're really shifting the structure of how that money comes in. But back at the state, we don't manage the 72 pots in the long run of, well, here's the amount of money that came from this county and the amount from that. And it's because that's just providing a base. A lot more money goes into taking people off the waiting list. So we don't have separate tracking of that funding. And in many ways, even in our legacy waivers, the state separates the money that we have and moves it out to 72 counties through the community aids formula, which is a really complicated formula. Having looked at it, it takes into account population, levels of poverty, socioeconomic status, levels of Medicaid eligibility. There's a lot of pieces that fit into it, and then the revenues that are generated by a county. So it's the money that goes back to the county, but it's come through the state revenue system. And then many counties, and Dane County is one of those, has local funding in, and that's what we would call local tax levy, which is typically through property taxes. So the question is, for areas where family care is there grumbling or rumbling from county boards that they're not getting everything that's equivalent to what they gave up? I think the biggest concern that we hear from counties is how the non-long-term care services that they still provide interface with long-term care. So a big area is mental health services are still funded through the county. But we have a lot of people who have enrolled in family care and IRIS who also have mental health needs. So, you know, it's making sure that we are coordinated on that and not compromising services to people so that it costs the county mental health system more, as an example. So I think those are some of the areas where there's a tension about keeping both sides of the partnership in place. But I think that counties are also well aware that people who were not getting long-term care services before are getting them now. So I would say nobody would tell you it's perfect, and I don't think anyone ever would, but I think the issues that are there are pretty workable. So the question is, why weren't people with mental health needs part of this long-term care reform effort? The first is that the populations Some of the services that they get may be similar, but the approach is very different. We're looking at people who have long-term care needs. Mental health and substance abuse is very focused on a recovery model. In fact, the idea that you aren't going to need that long-term. Certainly there are some people who do need services long-term. The second thing is mental health services, by and large, between the age of 18 and until you get to age 65, are not allowable for home and community-based services waiver funding. I have no explanation as to why that is, but the Social Security Act does not include people who don't have a long-term care need under that authority. Our mental health system has written a different kind of waiver authority to try to be able to get more federal funding into the mental health system. So some of it is just that history of different systems. One of the approaches that my mental health counterparts in the department are using are some of the new medical home structures that are available federally that are so misnamed because people think of like a building or something, but it really is about care coordination, and we have several of those initiatives moving forward for people with mental health needs. The question was more things to support the inclusion goal. So this picture that I have up, we've been using largely in our children's system and doing training for county support and service coordination providers in sort of an older nomenclature, the care manager kind of function. For IRIS, our self-directed supports waiver, we've been working with people in their teams around how would this look in your life. And a somewhat different vehicle, but it is the same thing that we're focusing on in family care. And when we're doing that RAD, that resource allocation methodology, you'll hear a lot of managed care organizations call that a strengths-based assessment. So we just don't come in and assess, well, you can't do this, and you would need help with that, and you would need assistance here. It's much more of that community mapping, circles of support kind of mapping of, well, who's in your life and who already helps you? Do you belong to a faith community? Do you volunteer at the local garden center? Whatever it might be. And by moving to that strengths-based focus, you begin to accomplish more of this. And I guess the other thing I didn't mention, we have used this approach very effectively for people who have been in an institutional setting, who move to the community often have been disconnected from everything. And so part of quality support for that individual is to look at how do you reconnect them to the community. And I kind of wish that Connie Lyle O'Brien was here with her lovely Southern accent that talked about one of the things that they realized when people moved into a community is taking a plate of cookies over to introduce yourself to the neighbors. And by the way, not putting it on chinette, but putting it on a real plate. And as Connie would say, no Southern family is going to take a plate and not return it. And so it's looking at what are those natural ways of connecting. Now the person returns the plate, and now you see them in the parking lot and you're waving and saying hello. So we're doing that kind of reconnecting as well. That's the best quality of a support plan for someone who's been separated from their community. So it is embedded in a lot of what we're doing. One of the controversial areas about doing that is employment, and whether employment is in a community rehab kind of a facility, location CRP, community rehab program, or whether it's in an office building or some other setting. So the question is, with this goal of being included in the community, what are we doing around how we work with schools and a concern about school budgets, being able to support special education. So a few things about that. We cannot pay in long-term care for things that other systems are supposed to do. There's actually federal prohibitions around that. At the same time, we don't have to just have a wall that says, well, you're under 21, the school has to do that and come to us when they don't. So an example is in our children's waivers, we've added new services. One is a mentoring service, and Jessica could probably speak better to this, so she can tell me at the end whether I was correct enough. But one is a mentoring. So that could include mentoring someone to do a volunteer opportunity, you know, so that they could continue that after school. We also have a community inclusion service that's now approved in our waiver. And it's the same idea of looking at how can we clear the path and create those kinds of connections like this for someone in the community. So we are looking at how we do that and trying not to be so siloed. We're also partnering with the Board for People with Developmental Disabilities, which is a statewide, federally funded program from the Administration on Developmental Disabilities. And they got a grant that we're working on, so it does provide some money to school districts. And then we also have some federal funding around encouraging employment of people with disabilities. It's called the Medicaid Infrastructure Grant, or MIG. And that also is giving, for example, a community rehab program that might have in the past had more segregated or sheltered services. This gives them some funding and incentive to create more community-based employment opportunities for people.